The problem is you do see a lot of antisocial people succeed. Loneliness is as big a risk factor for ill health and death.
We live inside our heads.
You go cold turkey, you go into withdrawal.
There is a lot of value in the stuff that we struggle with.
Better Thinking. Conversations with experts exploring all things psychology. Welcome back to Better Thinking. My name's Nesh Nikolic, and my guest today is Dr. Stevan Nikolin, who is a neuroscientist and clinical researcher focusing on depression and how depression affects brain activity. His hope is to inform how current treatments can be improved and also explore the development of new treatment methods for, in particular, treatment-resistant depression. An absolutely fascinating conversation today with regards to exploring what treatment methodologies might be available in the future, his research and how that could be applied to looking even beyond that with AI applications, and also looking at where some of these challenges take place in regards to depression formulating in the first place. I hope you really enjoy this episode because I felt inspired afterwards, and I hope this is something that occurs for you because this is an area that I think could really gain more and more traction and support from researchers, hopefully grants and aids in exploring this further as the need is ever increasing in today's world. Thank you. Steve, a big thank you for coming onto the show today. I'm unbelievably excited to talk to you about not only the work that you're doing, but also the knowledge that you hold in this space of neuroscience and being a clinical researcher, looking at depression, how it affects brain activity and what are the treatments that we're starting to explore. I know that there's so many out there, non-invasive approaches. We've got these novel ideas these days. Some might say novel, others might not, but around ketamine, for example, and psilocybin. There's many different angles, and TMS and the like. And I know there's the intracranial other stuff as well going on. There's so much going on. Excited to hear your views, your experience, and I know you do so much research in this. So thank you. And maybe I can start with how you got into this space.
Yeah, well, thanks for having me. So I came to my research by a very circuitous route. It was completely serendipity. I finished my undergraduate degree, and then I went into a Master of Commerce initially, and I realized very early on it's not for me. I stuck with it, and I managed to get a degree at the end of it. But in the middle of that degree, I happened to get called in to be a research assistant in a place that focused on Neuroscience Research Australia. Exceptionally great work. We looked at child injury and reducing injury rates for children in car crashes. That was very rewarding, but it wasn't quite the intellectual stimulation that got me passionate.
Sure.
And so what I ended up doing is reaching out to some researchers that I'd happened to read about that were literally across the street from me, so the building next door. And they were doing this exceptionally fascinating research, looking at non-invasive brain stimulation for depression. And I thought that was absolutely just mind-blowing. And I have, a family history of depression. So I've got family that has depression. Like many people, I know many of my friends have gone on to develop it. Some have had sort of good fortune. They found good medications. My family members have, very luckily. Others not so much, and it took a lot of trial and error, and some are still in the process of trial and error, unfortunately. And so I saw that research. It connected with me, and I started volunteering with that team while working in my old team, focusing on child injury. And after 2 years, I made the shift. And so that was 12 years ago now, which has gone by in a flash. It's crazy how quickly it's gone by. And so what we work on, broadly speaking, is we look at existing forms of treatment for depression, and we really focus on what's called treatment-resistant depression. So
Sure.
these are not people that are coming in to an office like yours for their very first visit. These are people that have usually failed at least 2 adequate courses of medications. And oftentimes, we'll see people who are quite severe who've failed 4, 5, 6, various combinations. They've tried almost everything under the sun, drug-wise. And so they come to us, and so we look at existing treatments like electroconvulsive therapy. And I don't know how many people are aware that ECT, electroconvulsive therapy, is still a pretty widely used therapy, and it's one of the most effective that we have in psychiatry for depression, but also for schizophrenia. So we look at improving ECT. We've done a few interesting things there that we can talk about. And then we also explored non-invasive brain stimulation. So non-invasive meaning that we don't have to cut the skin open, we don't have to surgically implant anything, we don't have to put anybody under general anesthetic. It's all, you're awake, you're sitting happily, and you receive the stimulation, and as soon as it's finished, you're more or less fine to walk out and go home, no problems. So there's 2 types there, a magnetic form of stimulation, and then an electrical form, and we've done a lot of research on both. And then more recently, we've expanded into novel treatments. And I think alluding to what you said previously, novel meaning the application is new, but these drugs have been around for a while. Sure. So we look at ketamine. Ketamine's been around now for 80 years, I think. It's that 1930s-ish. And then psilocybin, which is, famously was very much around in the 70s, 60s and 70s.
Sure.
And both of those are finding a sort of new life in depression, and specifically in treatment-resistant depression. And so that's some of the stuff that we're doing. So that's what I've been involved in. And in addition to working at the kind of patient end of the spectrum, my research also goes into the preclinical side. So doing work in healthy individuals to try and see if some ideas have legs and then can eventually make their way into the clinical space. So new ways of giving brain stimulation might be an example. We don't want to do a multi-million-dollar trial. We have to, start small steps, baby steps, and then go from there. Yeah.
It's so exciting because I've historically had, an aversion, if I can call that, because quite passionately concerned about things like ECG. But certainly in my practice over time, being able to observe how infrequently it's used. And that's the idea behind these. Not sure how to properly categorize it, but it's not a frontline service by any stretch of the imagination. No. And I think there's such great merit to be looking at what are all the options when we've exhausted the traditional ones and they haven't worked, and that's their idea of treatment resistance. And at that point, I think, like a lot of things, if cancer is not responding to the traditional measures, yes, we want to go out and throw many things at it. Obviously, with the do no harm model, which I think is very well established these days. But it allows us to start thinking in unorthodox ways, to be a little bit more curious, creative. There still comes with a theory in mind, and then we put it to practice. And so long as it's done under, strict protocols, which, we don't have lobotomies and those sort of things occurring anymore in the 21st century, thankfully, and we've learnt from that. But it allows us to go out and say, hey, we can trial some things, and if it has some legs, let's review a little bit further, and so on. And I think this space is quite exciting. It's even to be hearing about. I know clients have been coming in and talking about their TMS experiences as an example. That feels like it's expanded fairly rapidly of late. And I've been able to at least hear some of those experiences, and that's been exciting.
Yeah. So, I mean, transcranial magnetic stimulation, TMS, has really exploded. And I think partly because it received funding from the government, or was put onto the PBS scheme. It's a Medicare item.
Sure.
And I think that happened in 2021. I could be wrong on the timeline, plus or minus a year. Time flies, I always forget. And since then, I think because of that support, you see just it was waiting to go. It's been in development for decades, and once that support kind of comes online.
Same thing happened with psychology.
Right.
There were probably 5 clinics in Canberra, 20 years ago, and now, I would say there's probably over 100. Once Medicare gets involved, that just means that you've got an army of GPs. You've got a funding mechanism, and it just explodes. I imagine it's quite rigorous though to be able to get government funding or Medicare funding. But it's exciting to be able to see that once something's incentivized, it moves, it works.
Yeah, and to your point before, I mean, you said lobotomies, we don't do that anymore, and research has changed, and it is so true, because now, I mean, the procedures that we have in place to do randomized controlled trials and in-depth studies, we are much more rigorous. We've learned from many mistakes in the past, and so now the way we develop our evidence base is much more rigorous, much more thorough, much more peer review, larger sample sizes, so much more criticism, justifiably.
Sure.
This is a vulnerable population group. You do need that rigor, and then even once you get past the research stage, that it reinitiates at the Medicare stage. So the government basically restarts that process more or less, and you have to not just have convinced your field, you now have to convince a whole army of bureaucrats who are checking in on what you're doing. So people should be reassured if something is on Medicare, it's gone through the 9 gates of hell, basically, to get there at this stage. It is a very involved process. We've been involved in we were involved in the TMS application.
Okay.
And we are.
When did that start? Can I ask? Do you know how many years?
It took, trying to remember exactly, it took more than 5 years from the initial application. I don't know exactly. It's so long. It felt endless.
Yes.
Definitely more than 5 years. And we are beginning a similar process with ketamine.
Okay.
Hopefully it's not as long, but it is a very high bar to cross to establish that evidence base. And not just the evidence, they don't just want to know that it works, right? Which is obviously really important. They want to know that it's safe. They want to know that it's safe long term. They want to know the costs associated with the treatment, what economic benefits people will get at a societal level.
Well, we've seen the major issue, and don't want to go into this in any depth, but we've seen the major problems when something's rolled out very quickly with COVID.
Yeah.
And I understand the need and the like, but when all those checks and balances are gone, and you can say, oh yeah, we fast tracked it, you can't. You can't fast track long-term longitudinal studies.
Yeah.
You can't do that in a computer and go, oh, we've simulated it and it's all going to be fine. No, you don't know how it's going to metabolize in a body, how it's going to affect different systems, what might happen in 10 years' time. And when you're rolling something out at such huge numbers, to find out that 10 years later, 20 years later, wherever it might be, you've got major health crises on your hands or issues that would just be negligent. So I can appreciate the need, and I know that people are desperate to get their hands on what's the next possible choice, because many people are already at the end. They've done the TMS and that hasn't worked. They go, what now? Give me the ketamine. It's promising.
Yeah.
Or psilocybin or whatever it might be. And like everything, so many things have great promise. At the same time, it's more complicated than does it just work. It's also very difficult to make it land on the ground and actually have a series of clinicians doing standardized delivery. That's going to be a great challenge in many of these things. And obviously things like ketamine will be driven by psychiatrists and teams, and under much more controls, I imagine, in the first instance. But I can see the importance of the rigor.
Yeah, and I mean, with both ketamine and psilocybin specifically, it is, like you said, it's a team effort. And I mean, we think the way it will probably be rolled out, and this is projecting, so things may not show, but it probably will be the case that, you know, it is something that pairs well with psychotherapy. There's some evidence that suggests that that is a much stronger effect. You know, kind of, I think the analogy is that the ketamine and psilocybin, they kind of unlock the brain a bit. They sort of free it up from the shackles of the depression, and then that's when a trained psychologist, psychotherapist, psychiatrist, whoever it may be, can come in and sort of chip away at some of the bindings of that depression. And, you know, doing that a few times, you might be able to take away some of that biological basis of the depression, help focus on the psychological basis using, you know, whatever techniques you teach people, and with any luck, create some sort of lasting benefit that might be, you know, you could potentially maintain so people don't relapse, they don't fall back into depression with relatively minimal additional treatments. And when I say minimal, I mean that's a number that is still up in the air. We don't know what minimal means. It could be once a month, it could be once every 6 months, it could be once a year. If somebody's lucky, it could be never. Hopefully it's never. I suspect it'll be a bit more often than that, but it's one of the interesting areas of research.
Yeah, I'm particularly interested in the psilocybin space because it connects so much with psychotherapy. And my understanding, and I'd love to hear your research and readings and the like, but so much effort goes into history taking, finding out what the actual, I suppose, underlying difficulties, at least theoretically, are, so that they can be specifically targeted during the intervention session, or the, I know there's language for this, but I'm not in the space, but, you know, in the dosing session, so that, you know, if you have, let's call it 6 sessions, 10 sessions of understanding what are we going to do in this dosing session, that the dosing allows for this, I suppose, the affect of the drug allows you to be extremely open-minded.
Yes.
Part of the great problem when someone is depressed, or in fact, they don't even need to be depressed, when they're locked into an idea.
Yeah.
You know, for example, let's say an eating disorder. If you are absolutely locked into the idea that all forms of food are excessive calories, and that's going to mean I'm revolting, I'm ugly, I'm going to run all this way, you're incredibly convinced. If there's a drug which kind of says I'm open to new ideas, I mean, that is incredibly exciting for psychologists, because it allows us to assist clients to see another viewpoint.
Yes.
Okay? And we've all had those types of experiences, and you hear it about, like, you know, the doctor said to me, if I don't stop smoking, I'm going to die. And it's like, boom, you open up your eyes on the basis of fear. Right. And it really touched you. We actually made that shift, you know, overnight. You know, daughter said, hey, please don't, you know, do that anymore. And, you know, the parents said, we never knew it hurt you so much. And obviously from a space of love, now that we know, we're going to treat you differently. So it has that unlocking capacity, is my understanding. And then there's a whole lot of integration sessions that kind of reinforce that learning to make sure you reinforce, concrete it in, integrate it so that you have those long-term gains. It's not like, hey, take some psilocybin, you have this wonderful trip, you get all mystical, and we just hope for the best that you have this kind of insight, but everyone's connected and it's just all about love, and we just pray that it works out,
and you're cured
while you've got PTSD, and it's so methodical, and it understands why we're doing it and what we're targeting. We're targeting in such a specific element to hopefully fracture that belief system and offer a new belief system that is obviously much more helpful. I'm not sure if I've got this all right, but love to hear your views.
Yeah, no, I think so. I mean, I should say from the outset that sort of where I sit in the research space in this field is that, you know, I'm more on the, you know, you can think of a spectrum of basic science right the way to interacting with the patient being the final sort of point, right?
Sure.
And so the research that we do at Black Dog, the research that I do, we all span that entire spectrum. So I do the preclinical research in healthy people, but then I'm also involved in randomized control trials, ketamine. So, and I've given people TMS as treatment, as a treater. So I've seen the whole lot, but I will say that I tend to sit more on the basic science end of the spectrum. And so I think you can look at how treatments like psilocybin or ketamine or any of these work, and it's all a question of sort of how much you zoom in. You know, what level are you slicing the data at?
Sure.
And so you know, to answer how I view this,
Sure, please.
I think, you know, it's maybe helpful to sort of explain how I view depression. I think depression is something that can come about. It's a very unhelpful word that we use to describe a kind of cluster of symptoms. It's like saying I've got a cold. If I say to you I've got a cold, you'll know what I mean. It'll convey an idea in your head. You know that I'll feel a bit crappy. You know that I've probably got a bit of a cough. I might be a bit snotty. You know, you've got a sense of certain things that it means.
Sure.
But biologically, a cold doesn't mean anything useful. It could be a virus. It could be a bacteria. It could be wrong. I could be saying that I've got a cold and I've just got a collection of symptoms that at this point in time seems like one, but may evolve into something a bit different. Who knows?
Yeah.
And so biologically, it's not super helpful. And so depression to my mind is a bit similar, right? It's something that we've identified as common between people, but what is underlying it is the question. And so we, or at least I should say, I'll speak for myself, think of it as being a problem that can arise from many different points. So it can come about because of sort of a psychological element, you know, your environment, whether you grew up in an environment of trauma, a war zone, abuse, something like that. It can also come about, and this is kind of the more popular understanding of depression, this sort of chemical imbalance is the phrase I think that most people will have heard. Neurotransmitter.
Sadly.
Yes. No, exactly, yes. Because it is reductionist, right? It reduces.
And it's incredibly theoretical.
Yes, as well.
You know,
as well.
We don't have a pathology yet that we can actually point to.
No.
And it would be lovely if we did.
Sure.
But yeah, it's very simplistic.
Exactly. And then I think the newer one that people might not have necessarily heard of as much, which is where, you know, my space as well, is this kind of idea of a functional abnormality, which what I mean is that we have our minds, our behaviors are governed by our brain activity, and certain behaviors are governed by patterns of brain activity. We call them networks. And some of those networks can be a little bit out of alignment, essentially. They're either too strong, too weak, both for different networks. You know, the analogy I often give is that, you know, back in the day, you might have said that somebody had, if somebody was limping, you might have been a bit simplistic and said, oh, your thigh is the problem. It's your thigh.
Sure.
But nowadays, a physiotherapist might say, right, well, yes, partly, but then we also have to do some work on your back. We also have to do some work on your lower back, your upper back, maybe your right leg instead of your left leg, because there's a compensation going on, and there's a network of muscles that are actually contributing to what we see seems to be an isolated injury to a leg.
Sure.
It's a collection. And so all of that to say that there are many different points or many different ways that you can arrive at depression, because any one of those three things, or a combination of those three things, psychology, chemicals, potentially neurotransmitters, and also this functional effect, any one of those or any combination of those could come together to lead to a problem that presents itself as depression.
Because we only see the
Yeah.
basic outward expression of it, which says I'm feeling, you know, a lack of drive. I'm feeling flattened down. I'm tired and lethargic.
Exactly. Yeah.
You know, I get tearful quite easily, etc.
Exactly.
But as you say, any one of those three, and certainly not discounting that there is very real evidence for chemicals, but to say it's a chemical imbalance.
No, yeah, it's simplistic.
But you're right. You know, we know this because you can change your state quite easily and quickly, and we often do by eating food or drinking alcohol, or whatever it might be. So there are factors, and you reduce your sleep. I'm sure that it changes how you metabolize lots of things. We don't know because the complexity is too great, but we know it's part of the three-factor approach, so to speak.
Yeah, exactly. And so to sort of extrapolate beyond that, if we know that there's a multifactorial sort of contribution that leads to depression, then kind of what is depression? And so depression is this kind of state that we can arrive at through many problems or combinations. And I think one of the common themes in depression, which you did mention, is that it kind of locks you in. You fall into this certain pattern. You withdraw. You sort of turn inward a little bit, and then you lock, right? You withdraw from society. You withdraw from friends. You withdraw from your hobbies. You sometimes withdraw from food. Some people, reduce their appetite. Some people increase their appetite, interestingly. But you do kind of lock in. And then you'll notice as well, I mean, I'm sure you've heard this from your patients. Patients will say that, I struggle to re-engage. I feel like I'm in a fog. That's very common. And all of that speaks to the fact that their minds are kind of in this, let's say, low energy state, this almost dormant, inward-looking state. And so what's interesting is that psilocybin, ketamine, and potentially many more treatments as well, they have this effect of unlocking the bindings that keep your brain in that pattern. So it would be, going back to the analogy, if you've got a limp, but imagine your leg is in a cast. Ketamine and psilocybin, they take that cast off you for a bit, and then a psychologist, much like a physiotherapist, would say, okay, hold these rails, let me guide you through these first few steps, and then you've got a nice window of opportunity to kind of help somebody relearn how to walk. And then usually, and this is in the early days, the depression tends to reassert itself to some extent, perhaps not as much as before. But you've already made some progress. You've already taught them how to take the first few steps. And yes, maybe
you've broken the inertia.
Yes, exactly. You've created some momentum in the opposite direction. You've created some momentum going forward now. So that's a way to imagine it. From my perspective, what I look at is, so I focus on cognitive electrophysiology. I analyze brain activity, and you can see one of the recurring themes, one of the largest evidence bases that we're getting now from EEG, electroencephalography, brain activity on the head, but then also things like functional magnetic resonance imaging, fMRI, other neuroimaging techniques as well, is that you have a network in the brain called the default mode network, which I'm not sure if you've come across before, but
I think I've heard it, but no recall. So keep going.
So it's the default state. It was identified because it's a pattern of brain activity that they noticed people were engaging in. And when I say pattern of brain activity, I mean
just observable.
Yeah, patches of your brain were lighting up.
Yep.
So if you kind of peer into someone's head, you can see that instead of being kind of quiet, nothing's happening, there are still these brain regions that are lit up and communicating even when somebody's not doing it, just sitting in a scanner.
Sure.
And so I liken it to the neutral state in the car.
Yeah, baseline.
Yeah, baseline. Yeah. And that brain state is associated with rumination. So inwardly directed thinking, mind wandering, generally internalized thought patterns. And what you find in depression and also many other sort of neuropsychiatric disorders is that it is hyperactive, it is heightened, it is exceptionally engaged and tight. And that is kind of the physical manifestation of what I was saying earlier, this idea that you're locked in.
Can I jump in?
Sure.
How do we know that? Like, what tells you that? Is it that you're looking in the brain and it's firing in a certain way, or that observable baseline is kind of running and is a consistent thing that you can see even while other things are occurring? How do you see it? What tells you that?
In terms of how we measure it then? Yeah. So I mean, the initial, I mean, the way we kind of find the issue in patients is always the same sort of pattern. We usually put patients in a scanner and we put healthy people, controls,
Sure.
not healthy people, but just controls, in a scanner, and then we see the difference. And you can see this difference in, by matching sort of 1-to-1, same age, same sex, controlling for other factors as well. And then you see that these regions stand out as being different.
And you might keep them in for how long?
It depends on the technique. I mean, with a scanner, scanners are usually about half an hour. That's how long they take. EEG is a faster neuroimaging technique. So EEG, you can get that information within a 5-minute scan. It's not as...
Oh, so it's something you can take a scan of and go, if it's present in this particular way, it tells us something. It's not like I've got to look at it for half an hour and do this averaging out and say it's there present more than the control. Or maybe both.
Yeah, well, we still need to average. So that's always always a factor. I mean, I know we'll say that we're at the cusp, I think, of a revolution. Thanks
It's
to AI.
exciting. This is like, oh my God, this is wild.
So we're at the cusp of a revolution. Everything we've done so far has kind of followed, and not traditional, because there are people doing incredible far-reaching work, but the general approach has been this relatively standard way of looking at things, which is we take 100 people here, we take 100 people who are matched, and then we kind of average everybody together, and then we look at the differences, which is really informative. It tells you at an average level, but as
very time consuming, very costly.
They're both, but informative
and good.
Absolutely informative.
Absolutely.
Unfortunately, it doesn't often tell us much about the individual. So it gives us it'd be like
population
level assessments, and population level assessments at this stage don't translate exceptionally well. They're always outliers, people who buck the trend. And, like the reason I say we're at this cusp.
And you're looking for, third, fourth, fifth line treatment.
Yeah.
So we need to be individualized.
Yes.
We're taking a punt over here as well, but we want it to be an informed punt.
Exactly.
The psychs have done their informed punt at the top end. The GPs have done their informed punt with, antidepressants, et cetera, et cetera.
Yeah.
We're trying to see, on the back end.
Exactly. I mean, and it doesn't need to be 100%. Few things are, but if you could say to somebody, we've got an 80, we've done some measuring on you, 80% chance that you'll do well on this because based on what we've seen, I'd be reasonably pleased with that. 80% would be great, right?
Yeah.
90 would be better, obviously. 100 would be even better still, but it's...
At that point, I think you'd take 20, right? Like 1 in 5.
Yeah.
Because, a lot of time those people are genuinely exploring, if we look at the depression space, suicide.
True.
And often there has been a lead up of suicide prior, or previous attempts. So yeah, anything is good, but certainly something of a 60, 70, 80. My goodness, that's they're high rates.
That would be good.
Yeah.
And so I think that's why we are at a very exciting point, because we've got all these artificial intelligence techniques, and we're starting to build data. Universities now have not procedures that are informed by the universities, but I think many researchers are now taking on this approach of starting to build collections of data, engaging collaboratively with other people overseas, and starting to amass piles and piles of piles. And as we know, if anybody knows anything about AI, I think the one thing that everybody knows for sure is that it works best with huge quantities. Yep. And we're starting to get there. It's taken a long time because of how, as you said, very time-consuming process. It takes a lot of time to find people, to screen them, to get them scanned, all of that.
And even now, I think there's a willingness with the regulation to be able to say we can actually keep the data.
Yeah, that's
de-identify it. Now it can go into a pool. Prior, it's just unheard of. I think there's a real willingness of saying, for the betterment of humanity, we can actually all have a big data set, and then it's like go world. There's researchers around the world use the data and interpret it, figure it out, use it in your application.
Yeah.
But we've got it, rather than I've got mine, and I'm not going to share it with anyone. You do it on a collective basis. Hopefully, that's occurring around the world more and more. because that's where we can unleash AI and kind of say, tell us what we don't know.
Exactly.
We'll guide you, but then come back and tell us something interesting, or that we can at least explore.
And it's coming. It really is coming. I mean, for me, because I feel like I've been at that transition point. You know, when I started at Black Dog, AI wasn't a thing, right? I mean,
Sure.
ChatGPT's only been around for a couple of years, at least very accessibly, let's say. And it always felt like we had to reinvent the wheel. You know, whatever research that we did, like you said, it's kind of our little guarded sort of treasure, but we're oftentimes replicating a lot of what somebody else did, and then only adding to it that fractional step forward. Whereas what would have been nice is if we could take what somebody else had done already and just apply our new theory to it, would have saved, I mean, honestly, it would have saved probably a year or 2 years per project. So if you add up that time. And so now, I mean, I will say, yes, people are sharing, and your listeners should be reassured. The steps taken to de-identify the data, again, really, really solid, really thorough. I've shared data on a public repository, Figshare it's called. That people may have
Look,
heard
if
of it.
it's not stringent, people wouldn't have it on there.
Exactly.
Right? I mean, period, because it's a medical record.
Yeah.
De-identifying it means that it's a human record.
Yeah.
And you know, that's what we need to be, a human record rather than an individual medical record. And once you do that, and I'm sure, as time goes, we'll be able to even plug that into a system that de-identifies it itself. You just submit it and it will remove the parts that it needs. We disassemble it. You already got it.
Yeah, no, we have that.
What am I thinking? That's obvious.
It's there. No, it's such a useful thing, right? And it's, I mean,
who's going to manually do all that? That's impossible. The expense is too high.
And I'll tell you, I mean, we do things like we've got MRI scans, so scans of someone's brain, so you can see the brain tissue. And
uploads.
We upload it, but we remove the face. We not only take away the name, the age, all the rest of it. We now remove the face from the scan, so that even the theoretical risk of someone,
which is this small, but there is. But let's do it anyway. You program it in once, and the whole world it just runs that way. You upload it, and it removes that bit. And it's phenomenal.
It's amazing. So it's exciting. It's really exciting. And I mean, one of the areas that we're looking at now is this default mode network. So this kind of neutral state that we go into, which has been associated. So going back to an earlier question you had, yes, we see it between patients and controls. We also see that it normalizes in people that have successful treatments. So you can see it being a bit overactive at baseline. 6 weeks later, after a successful course of X, you see a reduction. You see trends like people that still have heightened levels are more risk of relapse. There's some evidence of that as well. So you see that there's all this kind of converging evidence.
But the fact that there's even a baseline that you can see, that's new. We don't tend to. I don't tend to think of depression that you can see in a scan.
No, and I should say that we're still not quite there as well.
No, but we're clearly, the research is around, can we, if I'm understanding this correctly, can we establish a agreed upon baseline for what depression looks like, so we can identify it. So on that basis, if we've got peer-reviewed consensus on it, and we've gone through all those stringent protocols, we can say, yes, there's an agreement in this, and hence why we can start doing amazing research, because at that point you can give lots of novel, not just ketamine and psilocybin. You can start playing with lots of things, just see what shifts the line, or shifts the needle. My apologies. And what are the side effects? And you can start playing with that, and there could be some very, very simple things that are available. I'm sure there'll be all the classic stuff like, what can you do? They cost you nothing, like running and exercise and so on. So, but there'll be other things that are very compelling. They come in pill form that might actually work a lot better than the current ones we have, which have got a limited success.
Yeah, and I'll give you a few examples of some interesting research in that vein. There's a study that was published in 2017 by a group in Canada. Drysdale was the lead author, and they looked at fMRI scans in a large number of people, so I think almost 300. And what they found is what they called biotypes. So biotypes, biomarkers. Essentially what they did is they looked at fMRI, so brain scans of brain activity. And they were able to find four patterns of brain activity that they then associated with the symptoms of, I believe it was anhedonia, so lack of ability to find pleasure in things, and anxiety. So they kind of had these two spectrums, I guess, to continuum.
Which makes sense because it's rare to find one without the other.
And
at least at a level, yeah.
And so they were able to combine those, and they were able to see that one of these biotypes, so one specific pattern of brain activity associated with this cluster of symptoms that you actually see at the behavioral level, one of those biotypes was, going back to what we said, had an 80% success rate with TMS. So the remainder were kind of, just low success rate, more or less average of a random person walking in the clinic. But this one specific biotype had this elevated potential benefit for TMS. And so I think that they're still working to develop that idea, ensure that it's robust, make sure that it's not a fluke, sort of an artifact of their own data set. I think, that's really important stuff. And so it could be many years before somebody builds even more support to really lock that in. If it holds, that's already kind of one biotype.
Yeah, that's
ticked.
That's 25%, so to speak, right?
Yeah.
Or at least of what's being targeted.
Exactly.
Like that. That's pretty phenomenal.
Yeah, and so I think that's the kind of aim. I think that it's a two-pronged attack that we're sort of lobbying. One is, can we take this label of depression and potentially split it up into manageable bits? So, this one might do all the TMS, that's biotype, whatever. There's this one, psychotherapy, away you go. There's this one, you're a bit tough, we'll give you, ECT, something along those lines.
Sure.
And then, once we've done that sort of side of things, then developing those treatments. And ideally, I mean, my kind of dream, almost like an alchemic,
yes, why not?
long-term goal would be, it would be fantastic if we had such an in-depth understanding of depression that we could create ideas for new interventions that actually make sense at the theoretical level. And by that, I mean, we have a really good working idea of what a virus is. So if you know what a virus is, you can say, right, well, it's this little cell. Well, I wonder if you can get a material like there's research on I think nanotubules or different sort of metals that interact with the cell wall and just burst it.
Sure.
So it's not it doesn't rely on the immune system. It's just a physical. It's kind of literally walking up and smashing the cell wall of a virus. But you can do that because you understand what a virus is. You understand what you understand what the disorder, what the illness is. And once you do that, you can brainstorm. You can say, well, what if we do this? What if we do that? What if we do this?
Well, in some way, that's kind of what ketamine and psilocybin are trying to promise. And the idea is, I provide this substance, substance A, and it bursts I have no idea what it does, and it's definitely not targeted on a certain thing, but it has some activation model that turns something on or off, or many things on and off. But it allows then the therapist to go in and do some of that work. Or it removes the cast, so to speak, which breaks the inertia, starts a little bit of momentum, which at least allows for a new perspective to be made. And some things are potentially resistant because some people's conditions are actually so awful, in terms of life trajectory and the like. But even then, it would be lovely to be able to help them with that type of scenario where you say, look, you might be on a trajectory and there might still be lots of grief and pain and suffering. But if we can actively supply something and reduce that, just your buoyancy, your capacity to sit with that means that you're less depressed.
Yeah.
And who knows where that leads? That can have a positive cascading effect.
Yeah.
That means that someone's got that momentum, different perspective, and off they go.
Yeah. And I think, I mean, the way I think of it is, our bodies and our minds are the same thing. Our minds are the manifestation of our bodies. And what I mean by that is our neurons, our brain cells and the way they connect. And what you tend to find is that the way you think is coded into the way your neurons are wired. So just like with a computer, and I know some people don't like analogizing sort of, human behavior with computers, but I think it's a useful way to think of it. If I've got a file and I save it to my hard drive, if I have a movie and I save it to my hard drive is going to write that movie into its physics, right? Into the whatever it is that makes up a hard drive. I'm not exactly sure. Something. So that there is this kind of physical component that is going on. And you can imagine that people that have had their depression for a long time, they've just rewritten over and over again on that hard drive, depression. You can imagine somebody engraving on a stone, right? And if every day you chip away and write the word depression on a stone tablet, by the end of a 20-year illness, you've got a pretty deep etching, right? And what's interesting about ketamine, psilocybin, and I think I would argue potentially even ECT, I think that there is some commonality between these treatments, potentially. Not proven, and this is me hypothesizing, but I think the commonality is that what they seem to do is they do seem to wipe that slate clean just for a brief moment in time. What they do is they do something called synaptogenesis and neurogenesis, mainly synaptogenesis, which is that the individual cells of the neurons are encouraged to form new branches, so new tendrils, which is how neurons communicate with each other. That's how we pass on a signal between neurons. And so rather than a very simplistic one-to-one connection, hyper efficient, always does the job, but that is very well-trodden path, that is like very locked in. What you do instead is you create these branches. And so now you've done that to more or less the whole brain. ECT, it's a bit more restricted because it has a spatial component. TMS, similar. But by doing that, you've now created the possibility to follow a different.
You've just the possibility of following something different. Interrupts the superhighway. Or it creates either fractures the superhighway so it's not a 4-lane a road, and makes it into a 2-lane and makes the other ones 1 or 2 lanes so that there's more choice.
And then you can do the scenic route instead of the way that you've always driven. You can say, I didn't realize there was this road here. I'm going to go this way. And the psychologist would be the signpost saying, hey, come this way.
It makes sense in terms of the etching, idea, and then using a chemical to try and free all of that, increase the dendrites and create more synaptic connection possibilities. And I say that because, psychology, one of the most powerful things you can do in psychology is called exposure therapy, which basically is saying, can you continue to rewrite a different path over and over and over again with logic, with experience? So if you're fearful of heights, get a little bit closer to the edge, sit there for a little bit, calm yourself down, bring yourself back, and do that over and over. We're trying to etch over. And we're trying to get to the point where we're actually etching over in the opposite direction, so that a height doesn't mean terror and fear. A height means heights, and there's an appropriate level of fear to keep you safe, but you're not paralyzed by it. The flooding mechanism in psychology says, I'm not going to do generalized, so I'm not going to do repeated exposure. What I will do is I will put you in a harness and I will lift you up on a crane, and you're going to go, 30 meters into the air, and we will hold you there kicking and screaming. So long as you're obviously partaking and
Yeah, okay.
and you go out and give consent.
Yeah.
And so the idea is that you're absolutely fearful, but you're fearful at a 10 out of 10.
Right. Okay.
So you will still come down from that 10 out of 10.
Yeah.
And you've fractured the belief of
Okay.
that, I wouldn't be able to handle it.
Right.
Because you eventually, after 40 minutes being hanging up there, you're like, oh, this is actually
Yeah.
quite interesting. But it might take an hour.
Yeah. Yeah.
Right? That's why we call it flooding. That's not something that's used very often in psychology, but it is another mechanism that's available. And I see something like ketamine, psilocybin, maybe the TMS, but you say it doesn't kind of flood enough of the it's more targeted at certain areas, but
Yeah.
there is something that potentially, at least theoretically, has a commonality there where you get to completely question that fear.
Yeah.
Because most people, after they have completely overcome that dreaded fear, a decent amount of the shackles that hold them there have been released.
Right.
There's a big movement. That's why with exposure therapy, no one asks their client to expose at the highest end. So you build a hierarchy.
Yeah.
You kind of say, what would it be like to, I don't know, stand on a chair?
Right. Okay. Yeah.
Right. And if the answer's 0, then you don't even attempt it because
Right.
it's got
There's
no
no
value.
point.
Right.
Yeah.
And probably if 1, you wouldn't even probably start there. But if they're very hesitant, you might. Right. And then let them build up to 2, to 3, to 4. And each time they get more and more confident. Someone who's a little bit more ambitious, they might say, I want to go for it. I've had enough. I'm willing to, go to a bridge that has a glass section and stand on it or something.
Yeah.
Right. And I'm going to stand there for an hour while I'm sweating profusely, my heart's beating. But obviously, not many people are willing. But something like, I'm going to take some psilocybin, some ketamine, there might be a lot more willingness and that's a powerful, I think, possibility if those two things are interrelated. I know it's a bit theoretical, but there seems to be like a potential complementing theory around them.
No, I completely agree. So I think the willingness, I think that if you already have that openness, if you to some degree, if you already have that willingness, that ambition that you said to do something, whether or not you're certain that it'll work, if you already have that, you've already kind of won half the battle, to be honest. I mean, if you've got that capacity to say, I need to do something and I'm going to try my level best. That's half, because if you have the other way around, right, you can give a really potent therapy, but if you're kind of internally closed off to the idea of it giving you any benefit, you're almost acting the other way, right? You're kind of almost maintaining your status quo.
Yes.
And
your level of resolve of being able to do something is very little. It's kind of like, and I hope I'm speaking correctly here, but for people who are experiencing extreme obesity, for example, it would be almost foolish, probably not completely, but almost foolish to be trying to start up a program of healthy eating and so on with a strong assumption that it's going to work. You'd have to be fairly, I would say, cautious about what the end result would be, because the result would have to be phenomenal.
Yes.
Right. And looking at a second tier, third tier, fourth tier, this is where we start seeing things like gastric bypass and so on and so forth. Ozempic, yep. And that's so appealing because so many people are like, I could try that. That's not hard to try. And it's very hard to try surgery, and it's irreversible. And I think there's obviously some concerns around Ozempic as well that people should be well informed about. But nonetheless, it's of that model. And when someone's deeply depressed, Yes, it would be wonderful if we said, try and go for a run, some sort of exercise, go for a walk, not even run, walk around the block.
Yeah.
The likelihood of them even maintaining that is so low. That's why they're at the level of suicide. Their despair is at the extreme level. The hopelessness is there. And so it becomes very, very hard for psychologists to do work that is meaningful, or at least strongly demonstrated as effective. It needs some type of aid. And it doesn't mean that psychologists would ever stop. There's always hope. You don't give up and say, oh, treatment resistant, can't do it. There's always opportunity, but it would be nice to have another aid that breaks inertia and so on.
Which is why, I mean, that's one of the reasons why depression is so pernicious. It's the mechanism that you need in order to enact change is precisely the mechanism that defines the disorder. Apathy is a hallmark. Lack of motivation, lack of drive, the cognitive fog is a common symptom as well. So, poor sleep, whether you're sleeping too much or you're sleeping too little, all of those things, kind of fatigue, the whole cluster of symptoms is fighting against you, developing the drive and the will even to do any of these things. So it's kind of a, how do you get the horse, moving if there's no horse, right? Like that's kind of the problem, right? Like, what is interesting is that, some of these, the new therapies, they do create these new pathways of brain activity. What's interesting is something like TMS, transcranial magnetic stimulation, seems to operate by a slightly different way, and it does, I think, potentially work. And again, me hypothesizing, this is kind of me just reading into what I think is the case. So magnetic stimulation doesn't necessarily work in the same way that ketamine or psilocybin does. It doesn't create this kind of like flooded neuroplastic state where you can come in and rewrite, the shackled depression. You can't rewrite that out of the brain. What transcranial magnetic stimulation does, TMS, is we tend to stimulate the prefrontal cortex. So there's these two regions just here called the dorsolateral prefrontal cortices. It's a mouthful. Most things in neuroscience are. But those two regions...
I'll just call it frontal cortex.
So you get used to saying it after a few years, but it is a mouthful. But so that these regions on both hemispheres, both sides of the head, are associated with drive. The prefrontal cortex is kind of what sets us apart as a species. It's the most developed. It's the seat of personality. It's what lobotomies used to be done on to sever, and lobotomies are absolutely terrible. They did work in the sense that they removed all personality. So you can't be depressed if you've got nothing.
Serious.
You've taken
serious stroke in your planning and organizing and personnel, everything.
Exactly. It's like it would be like amputating a leg if you had a limp. You've got no more limp.
You don't have a limp.
Well, you've also not got a leg, so that's one way to solve the problem.
And now you're hopping funny. So you take the other one off.
Yeah, exactly.
Oh, that's good. They're no longer moving around hopping. That's
so that, but I mean, it does tell you that the prefrontal cortex is really important, especially for personality, for drive. And so what TMS seems to do is by sending these magnetic pulses, it encourages the neurons to fire. And just like if you went to the gym and you encouraged your muscles to fire by doing an exercise, and if you did that every day, several weeks on end, your muscle would naturally adapt. It would take on that stimulus. Your muscle says, oh, I seem to be getting a lot of work. I need to kind of beef myself up so I can handle all this new stimulus. So the brain is the same, it's biology. And so all these magnetic stimuli that we send into the brain, they kind of force it to work a bit better. We light up this prefrontal cortex. We have some downstream effects, that there's a flow-on effect to other parts of the brain as well, but not just the bit that we stimulate. And what seems to be the case is that in the patients that we treat, we notice this relatively consistent pattern. Most of them develop or regain their motivation their drive, their they reattach with their network of friends and family. All that happens, but all of that happens while they still say that they have not shifted the needle at all on their depressive symptoms.
Mm.
And what's interesting is that,
Geez, that's fascinating.
so it's going back to your,
There's some type of behavior activation going on, but the mood side hasn't shifted too much, at least their reported experience.
yeah, and so it takes some time for the mood to catch up. But what is interesting is that what you've done is you've given them drive.
We also know the precursor to feeling better is that you're re-engaging more and so on and so forth.
Exactly.
So,
And so these people have kind of rediscovered, first they rediscover their ability to engage, to self-direct, to choose potentially to do things that they know are advantageous to their mental health. And then, they do those things. They call up, they call up their lost, the long lost best friend.
Sure.
They start going to gym.
yeah, they
Because
say yes to an invite.
They say yes to an invite.
Yeah.
And so it's interesting that it seems to be another angle, so rather than kind of rewrite and rescript, what we're doing was saying, okay, no, we'll just give you the tools through this external factor. We'll give you the tools to essentially chip away at your own depression. So again, we're kind of unlocking these.
That's why there's such different novel approaches. One is kind of saying we're going to do a chemical flooding, so to speak, at least in theory, it seems plausible.
Yep.
That's going to have an opportunity to rewrite, have a new perspective, break the belief, etc., and maybe some excitement as well of behavior activation. The other one's saying we're going to do stimulation, but through magnetic impulses, and we're just going to fire it, and on that basis you're going to get more activated. And we naturally lean to certain things, and as you said, there's these measurable changes with behaviors, and then hopefully the mood catches up, which is very plausible, because if you're starting to do those things, we've broken that inertia again. But they're different approaches, because someone needs to help with the rewriting in one, and it's such a limited space, at least of that big powerful dose session, and then plenty of integration. And the other one's very, from my understanding, uninvolved, in terms of you just sit there, this happens, 15 minutes later you say thank you very much, I'll see you tomorrow, and you walk out. But the affects are still there in terms of all those behavioral things. It's fascinating.
It is
different approaches.
And I will say, I think it is a shame that we don't, for every treatment, do a more holistic approach where we engage people on as many levels as we can. So going back to what I was saying about, what kind of combines together to make up depression, whether you have the psychological element, the kind of environment, your history, your trauma, so on, the chemical imbalance, and then also the functional, connectivity, how your brain communicates with itself. It's a shame that we can't tackle all that simultaneously, throwing in as well nutritional advice, exercise advice, socialization. I mean, it's a very involved, what I'm describing is very involved, but it's a lot of work, and it's the reason we don't do it.
I'd like to think, and I'm an idealist. I am an ultimate optimist as well. I'd like to think that one day, probably not in my lifetime, but one day when we're released a little bit from the shackles of work through robotics and AI and so on and so forth, maybe we can place more manpower to things like helping others. And so, it would be phenomenal if life took a downward trajectory and you had a team around you. You could develop a strong therapeutic relationship who are actually unbelievably encouraging and supportive and really available to get that momentum, because it's so much easier if someone made the food for you to eat and then said, well done, good on you, buddy, you're doing so well. With that level of encouragement, it's hard not to. If all these things had the manpower then maybe we wouldn't be looking at maybe we'd be looking at mental health in a different way as well, because what all those layers that may be added to why someone's feeling that way would inadvertently be treated by some of that care. But you know, that's my ideal mad space. But maybe it's not. Maybe it's not, because I think technology one day will change the labor force and allow us to do things. And we just want to work anyway. I mean, human beings, I think, do enjoy working.
We enjoy purpose.
And I can see that a lot of people would like to help. And if you know, robots are doing many of the things that we don't like to do, we can do the helping part that we love to do and say, no, robot, I'll do that bit. Thank you very much.
No, I mean, I hope you're right, and I hope it does go that way. And to be honest, I mean, it may come sooner than we think, because I mean, we are really staring down a significant crisis when it comes to depression and anxiety. If you look at the latest statistics, I mean, just specifically in Australia, if you kind of look at the trends, it's getting worse and worse and worse. And we are now, you know, if you look at serious illness, so depression and anxiety, in terms of percentage of population, it's above hypertension, you know, it's above diabetes, it's climbing. That's the worrying thing. It is actually climbing, and it's climbing in the young at a faster rate. So, you know, people, I think the age group is sort of teens and 20s, that age group. So, you know, hopefully it levels out and starts to go back down. But if it doesn't, and it continues on this trend, then people may need to start thinking creative solutions like this now, just from pure need.
Some of them, you know, a number of those, you know, become chronic illness. You know, it's not an episode. You know, some of that converts into chronic, and you know, it's quite debilitating for a long period of time.
For an individual, but then also for a society.
For sure.
And that's the thing we need to bear in mind. You know, it's one thing to focus on. It's important to focus on the individual, and that's obviously, you know, that's my area of research. That's what I do. But then we do need to think about how does this change the fabric of the society that we live in, where we are. You know, this is becoming a more and more prevalent issue.
What's pushing the stats? If I mean, we're purely speculating. We're just throwing ideas around. You know, not going to quote you, but you know, for me, one of the big ones is at least for the young, having read Jonathan Haidt's book, Anxious Generation, and Coddling of the American Mind. Some of those things seem really well researched and quite plausible, and I think well put together. I think they're great essays. There's definitely a strong interaction with social media, you know, computer use, the way that a lifestyle, what we're looking at, that the opportunity loss is a big one as well. You know, I think the way we socialize is so different, and we know from a developmental psychology, not that I'm strong in this area, but we know that kids need certain things at certain times in development. You know, whether it's vision, whether it's language development, whether it's social development. You know, this is why we've changed how we do schools. And do you do academia at this time, or do you do more play-based social stuff? So I think that the fabric of how we live has changed so rapidly. That is a huge contributor. It's not the only thing, but I feel it's a very strong contributor. But I'd love to hear your views rather than me just repeat my views.
I don't know that I have much to add, because I completely agree with you. I think you've said all the main. I mean, I think social media has played a really big role. I think we are social creatures, so we naturally compare ourselves against others, and you know, you can think of depression as a protective mechanism that in healthy people allows you to withdraw due to emotional damage. You know, so depression not as a chronic condition, but as a brief state. As a brief state is a way for you to just kind of go back in on yourself and recover from something really traumatic. You know, a loved one passing away. That can put you in a 1 to 2 week dark mood without interacting with others. Because to be honest, I mean, you know, you're not going to be exactly a pleasant person to interact with. So maybe as social creatures, we've evolved this kind of protective element to say, look, I'm going to be harming my social capital if I interact with people at this point. I'm not exactly going to be the belle of the ball. I'm not going to light up a room. Better that I just stay in my room, process all of this that's happened to me, and then in a couple of weeks, I'll start reaching out again, and I'll eventually reintegrate, and I'll be able to move forward. But I think social media, it hijacks some of that system that we've evolved, and I think it can potentially light it up maybe too frequently, in the sense that same with anxiety, like we've evolved anxiety. Anxiety is protective. Anxiety is meant to give you a sense of worry for something that could potentially harm you. It's a useful, just like fear. Fear it's not pleasant, but it is useful. We're afraid of things that could harm us. But we now live in a time where we have access to our phones, and we can connect with things that trigger that anxiety, trigger that depression far more regularly than I think we were necessarily evolved to handle.
Something that just jumped up, and hence why I'm writing it. While you were talking, don't know why I fired off, but maybe there's an addiction. Let's not call it an addiction element, but when we look at addictions, we say that someone engages in an activity, alcohol, drugs, pornography, at enough of a level that they are neglecting other areas of their life, or it's having a direct impact. So if I were drinking too much alcohol, it might not necessarily affect, let's say, my work, because maybe I can maintain that function. And so we say, okay, it doesn't have an affect there, but it might socially affect things, or it might have health problems. I might not attend certain things that I should be attending, which erodes that, like let's say going to sport with my children, and it erodes those relationships. Maybe there's a same element of the addictive quality, the entertaining quality, I should say. It's so compelling. It's calling out your name all the time. It's individualized.
And it's algorithmically designed.
Absolutely.
To pull you in.
So it wouldn't matter what it is. If I was such a football fanatic that I missed out on important events because I just wanted to watch football. And if my partner's really unhappy with me, I'm angry with her back because leave me alone. I just want to watch my football. I'm doing nothing wrong. It starts to erode things.
Yeah, that's a fair point.
So maybe there's something around when we start stripping away all these other opportunities, life becomes more and more depressing. I mean, I'm enjoying this conversation. I get excited about this conversation. We only just recently met, right? And even though we don't know each other, something has occurred where I feel inspired. I'll go home and my wife will ask me, I have this great podcast and these insights. I feel like I'm learning and growing. It's interesting to meet someone new who's intelligent and so on. So there's something about that would be lost if,
we're just scrolling on Instagram right now.
I'm sure there's plenty of things on YouTube I could be watching, which is a repeat of what I was watching last night.
And
the night before. It's brainless repetition of nonsense. So maybe there's something there. I've never thought about it as an addiction, so to speak. And I don't think addiction is right, but I think it's so strongly compelling that it pulls me from other things, or pulls humans away from other things.
I think I completely see where you're getting at. The idea that there's the opportunity cost in your developmental pathway. This idea that rather than interacting with friends at a pivotal point in your life, oftentimes the friends that we make for life are the friends that we make when we're sort of teenagers. That is That is a very formative set of years. I'm still in touch with people that I was bandmates with, when I was 15, 16. I mean, we all do very different things, very, very different things. And, I don't get the opportunity right now to interact with people that are from such different walks of life, because I generally meet people, in the limited time that I have in my day, more or less similar to me, in similar fields, similar interests. But those years are so valuable. They teach you how to interact with people of a wide range of temperaments, interests. You get really close because you're all discovering new things, whether partners and all of that is happening at the same time. But if you're kind of just scrolling on Facebook, you miss a lot of that. And I think I see what you're saying. In addiction, it's kind of,
it feels like there's lots of opportunities that are missed that we can't even identify. Like, it's very nice if you're doing a long trip and you say to your child, here's an iPad so you're entertained. But you've also robbed them of the opportunity of fighting with their sibling. I get the idea that we don't want them as parents to fight. At the same time, having a fight and working through it requires many thousands of repetitions to downregulate as a opportunity, to negotiate through it as an opportunity, to put in boundaries as an opportunity, to punish the other through saying, I'm not going to play with you, and reciprocation and like, it helps parents maybe moderate their behavior and learn new skills rather than this one works because I don't hear for him for an hour. There's so many, and that's the smallest of thing.
And even boredom, even learning how to be bored, even learning how to stare out of a window and captivate yourself with your own thoughts.
The capacity of boredom.
That's it's not again, boredom is not pleasant. Most of us don't like being bored, but being bored is what then teaches you how to engage.
Because you better learn it. Life's going to be hard if you can't hold boredom.
Exactly. And you're right. I think there's a lot of these, and I think maybe the broader point is that we are still as a species learning how to manage short-term benefit relative to long-term detriment. I mean, like it's only relatively recent history, if you look at that sort of the span of the human civilization, that we introduced rabbits in Australia, and look how that went. Cane toads, beetles. I mean, there's so many examples of that, right? So that ecologically, there's many examples of that. I wonder if we have just as many examples. I bet we do psychologically, where we say, I'll give you an iPad. Short term, you're quiet, but long term, what have I done to your development? I say that without knowing.
Sure, but I think it's holds reason to consider. Obviously, the great challenge is always how you put something into scientific method and funding. But even there, I could quite easily consider the value of quiet. A Vipassana meditation. I'm not sure if you're familiar with that, what that
meditation
is.
Broadly, but not.
So Vipassana is basically a practice of silence, and so you remain silent. You go about your day, and you've got activities that you do. Part of it's meditation, another part might be some yoga or something. At least the modern version, and so you're practicing the silence, and then practicing silence combined with for example, mindfulness meditation, you're observing your thoughts, and you do this for multiple days. That is, if we think about it, a practice of rewriting observation, observing the mind and how it talks, sitting with discomfort, boredom, your own personal agitation. So you've got to figure out how to downregulate. There's so many things that come from it, and it's like, I'm going to give you a dose of 10 days of silence. I bet that would have some pretty impressive things if we then put someone under fMRI or something or other and go, what's the pre and post? Obviously, the willingness is always going to be quite challenging. It's so much easier to do a 15-minute, rather than you're going away for 10 days. At the same time, I think there's plausibility to think about these things of if we did boredom as an example, because I know Vipassana isn't boredom, not
but
by any stretch of the imagination,
it's
but
stillness,
but you can see stillness, mindfulness, just being present and alone. You have to develop these skills.
Yes.
Um,
And on that point, I mean, what's interesting is that, I mentioned before that, in depressed individuals who have depression, you see this like hyperactivity of the default mode network, so that the brain state when you're internally directed. If you put experienced meditators under the scanner, what you see is that there is less activation. So those people have the experienced meditators, and it's a scale. So you can look at novice meditators, intermediate meditators, and then experienced Buddhists who've done 20,000 hours of meditation collectively in their lives. They could sit still for a year and it would be just like a piece of cake for them. And you can see, if you measure everybody's default mode network, you will see less and less activation as you get more and more experienced. So even though they're quiet, even though they're in a state, I mean, if you or I were to sit here and close our eyes, within probably about 15 seconds, if not sooner, I would be thinking about my chores for the day. Did I take out that laundry? Okay, did my wife tell me to buy some milk, or do I, my mind would go there just of its own volition.
yes.
15 seconds, honestly, would be generous. It should be as quick as 5. And so all of those thoughts, that's the default mode network. That's the internal planner. That's the, kind of scrubbing the inner recesses of your mind to plan ahead. Meditators don't do that. So they close their eyes. They're there. They're not digging into their list of chores. They're just sort of,
And
present.
they're not wrestling with the thoughts.
No.
When the thought comes up, they don't they don't get into it. They're not as irritated.
Yeah.
They don't get agitated by it. They're not
it's in
judging how well they're meditating.
Yeah.
They're doing the practice, which is observing, and not the non-judgment.
Yeah.
Many thousands of hours, as you say. That makes so much sense. That makes I had no idea that baseline can be shifted.
Well, and
or observed, my apologies, and therefore shifted, because with practice it moves.
And it is one of the areas of research that I'm in at the moment. So one of the studies that we've got underway right now is that we're testing the use of a monitor, a brain activity monitor. So EEG. This is electrodes placed in the head that monitor EEG activity. And we've been able to detect the switching on of this default mode network in real time. So as it lights up, we can say, oh, there it is. And so what we're attempting to do now is to
Is this like through the day, like in somewhere, also for a period of time?
For a period of time.
Sure.
I mean, it's not an invasive setup, but it does take time with an expert technician. So it takes like 20, 30 minutes to set up.
Wow.
So it's not something you can easily.
Sure, it's laborious.
Yeah,
sure. It's there's an investment. Yeah.
So, but we've done it, we've done a 30-minute scan. And so in that time period, your default mode network, when you're just sitting staring at a screen, lights up roughly, let's say about 10, 15% of the time. So the brain is not always in the default mode. It's kind of always switching in and out, kind of scanning something else. Oh, what was that? Did I hear a sound? Oh, okay, what are my chores? Oh, was that a sound? Did somebody ask me a question? What was that? What was that chore? So we're not static.
Sure.
Right. And if anybody interrogates their own minds, I think we all know that.
Absolutely.
But we do kind of cycle through. And what we've been able to do is identify when this default mode network switches on. And the study is ongoing. I'm hoping that the data collection will finish by the end of this year, so November, December. But I can tell you that in having done it myself, so we pilot on ourselves always before we do anything in a trial. And so having done it myself and being, on that spectrum of expert to novice, being firmly a novice meditator, I'm not very good. But I sat with the device, and it's fantastic. We rigged it so that when it detects the default mode network activity, it sends off a little chime and a flash of light. And I would be sitting there attempting to meditate, and I would inevitably get lost in thought.
Yes.
And what's fascinating is that usually my usual experience is 30 seconds go by.
Yeah, before you notice it.
And then I say, oh, hang on. I've just been daydreaming about going to see that film that I wanted to see or whatever it was. And then I kind of go back. So in a period of 5 minutes of meditation, I'm probably lost for about
Most of the time.
exactly 4 minutes.
Yes.
With this device hooked up as we were piloting it, you know, I noticed as soon as I started thinking to myself, I wonder if, you know, Thingy is going to call me. Ding. Oh, okay. Yeah. And then, oh, I wonder if Bing. And it was such an amazing experience because it really felt like somebody was holding my hand, you know, and guiding me from the inside, which is not something that you typically have with mindfulness because nobody usually has.
Imagine I'm wondering whether this could bring the value of meditation upward, meaning if you're doing more time in the observer state rather than the base state. If your base state is being interrupted each time, it gives you plausibly more opportunity to be in the observer. And that's what someone's trying to, in actual fact, practice over 5 years. You know, how many minutes of observer have you been collectively? And if you've got, you know, 60 hours of observer, which I can imagine would be an extended period of time, is most of the time we're in base. Anyone that's tried would definitely know that. But I can imagine that the efficacy of mindfulness practice potentially could go up and push you forward. Because imagine the Buddhist monk, but you know, someone who practices that practice, did that from the beginning. How many more hours they could potentially have, you know, or how fast they could develop to that state and get all the benefits. And truth be told, you know, I've done a Vipassana sort of retreat or exercise experience. Geez, that changes things. I'm forever changed. You know, and I've done it once. Having said that, I'm quite comfortable to have quietness. You know, I will go camping solo and have no one, which I love. There's something so beautiful about that.
Hope you've got a satellite tracker when you go.
Definitely not.
Oh no.
That's the point, to get away. You know, and it's fascinating because that whole experience of not having to ask anyone. And people have this where they live alone. They don't have to ask someone for. Yeah, but when you are living with family, there's forever conversation. There's forever negotiation versus saying, I want to do this. You know, that silence is interesting, but probably a little bit of a segue, but geez, that is, I can see the applications of.
And we're digging into it, so hopefully some of the things that you've said will come to fruition. I mean, we've got it's a long pathway. You know, research takes a while. There's a lot of things to set up, and there's a lot of building blocks that you have to stack on top of each other before you get to clinic. A lot of building blocks, but we are really hopeful. I mean, we're looking now at finishing up the study, and then with any luck, you know, assuming the results hold, we're hopeful that, you know, the next stage is we can build it. We can examine how it works as part of a program. At the moment, it's just a one-off. People come in 20 minutes. We're hoping to see what happens if people come in and do, let's say, a couple of weeks, so we can potentially address some of that question. If it still does what it's, you know, we're hoping it does, it could shorten the pathway. That's one potential benefit. The other potential benefit is that many people quit mindfulness, and not to say that mindfulness is useful for everybody. There's definitely people that maybe aren't suited. But for those that are potentially suited to mindfulness, many of them actually stop doing it because of the frustration, because they find that 4 minutes being lost in thought out of a 5-minute mindfulness session is just.
You could gamify it.
Yeah.
Because that's effectively what, you know.
Oh no, yeah, absolutely.
That's the biofeedback model, right? I can observe myself. I'm doing, you know, I'm at a 3 out of 10. I want to get to 4. That makes it interesting. I can tell my mates, maybe it can ping them and tell me now I'm at a 4 and they're at a 3, and there's a competitive streak going on. And the idea, I imagine, would be just if you do a little bit, that might be the same effect of breaking inertia, getting a bit of momentum. Means that some of the fog might reduce. You make some decisions behavioral activation comes out of that. There's so many applications. Yeah, wow.
Yeah, and we're hoping that we're sort of thinking that, and again, this is really early days, so a lot of this is idealistic, optimistic, wishful thinking, but assuming it holds, we're thinking of it more as kind of like training wheels on a bicycle, right?
Yeah.
In the early days, yeah, you have a bit of support, and then as you progress, as you've logged those additional hours, as we detect based on the brain activity that we see that you are starting to self-regulate, we can make those training wheels less supportive as time goes on. We can pull them back. We can alter the threshold at which we step in. We only step in if you're really lost in thought. We'll let you regulate the easier cases. And then as you get better at that, we'll kind of keep shifting it so that you don't need this anymore. And then you are now,
absolutely,
qualified Tibetan Buddhist kind of,
And there's even, the application of AI of saying, how are you responding to the number of prompts? Because some people will be agitated, and maybe these things in future, if it holds, and maybe there's a commercial way of building these out, but if it holds, to have that individualized thing of saying it agitates one person, but another person that they like the rewards, or it gamifies in the way that someone wants to be gamified. So it's actually more enjoyable for each, rather than the game is set and everyone has to fit the model. No, might actually go out and say, we can see more base state by virtue of prompting you too many times. You're starting to get more agitated, so the prompt is no longer reminding you. So we might want to change it up to help you, because it's about the aid, the facilitation, the help, rather than because that's the ultimate end goal, right? I don't care how a psychologist gets someone to get out of bed.
As long as
CBT, ACT, which is my passion,
right?
Or ketamine, or who cares if it's a loved one? You just want them out of the bed, right? Engaging in life. That depression is a deep, dark, awful space, and in its clinical category, not like a depressed state, but depression, major depressive disorder, when one's fully in it. We've got to start looking at these novel things. So where can people find out more? Where do you continue the conversation? How can people even get involved if there are students out there who are excited by this? How do they start to explore a path like this?
So I mean, I've withdrawn from social media, going back to the conversation that we had before. I found that it sucked up a lot of my time, and I'm now so busy that I really cannot afford to be scrolling on Instagram very much. But people can search, if you search my name and you search either Black Dog Institute, or if you search University of New South Wales, so UNSW. If you combine my name with either UNSW or Black Dog, you'll find on both of them I have a page. And on that page, you should be able to track down my email address. So if anybody's interested in reaching out, I'm much more likely to contact and communicate with people via email. I think I do still have my Twitter handle on there, my X handle, but I've stopped looking at my notifications. I apologize to people if they messaged me and I haven't responded. But if anybody is curious, if anybody would like to reach out and either be involved in some of our research as a participant, we're usually on the lookout for participants. So feel free to let us know. I will say that we can't take on everybody. We always have ethics regulations state that we have specific criteria. So we may or may not be able to include people, but if you're interested in finding out, please send a request. And if you're interested in being a student under my supervision, I'm quite full. I've got 5, I think, and I think the max that you can have is 6. So if someone out there is exceptional, I'll consider it.
Get in quick.
Yeah, get in quick, first in.
Or find out who the other 5 are, and sabotage.
We'll have maybe we can gamify and turn it into some sort of game, Squid Games, academic style. But yeah, please send me an email. And if anybody has any ideas based on what I've said, interested if you've got any publications that you think that I ought to read. Why not? I'm always open to ideas.
And nonetheless, if someone wants to, get involved at UNSW and start rubbing shoulders and be part of that whole space, I think it's so fascinating. The applications are immense, and I think this is an area of great need. The numbers are rising. We need more treatment modalities, approaches, or at least to be researching it, so we find something for each person where possible. And this sounds incredibly exciting and promising. Requires a lot of time and effort. So appreciate your efforts and your work. It's great to be able to have this conversation. It's inspiring for me. Psychologists do one side, and to hear how much effort goes into work like yours is phenomenal. And to be able to have, I think a collective approach that looks after the whole community is important, that we can lean on each other and support each other and be excited by each other's work. So appreciate you and thank you for your time, and all the best with research and uncovering some of those great questions.
Thank you very much. Thanks.